Hi everyone, our subject today is extremity pain in pediatrics. Basics. Muscle pain, myalgia, is a non-specific finding in many conditions. Evaluation of other aspects of the history and physical examination, joint pain, weakness, toxin exposure, systemic complaints, or other physical finding may be more useful in narrowing a differential diagnosis. History. Be aware of possibility of unopposed trauma as well as intentional trauma, child abuse, particularly in the preverbal child. Inquire specifically about the lifting of a child by the child's extended arm, which can cause a radial head subluxation. How to approach to extremity pain in a child after performing history and physical examination. Is there history of trauma? Consider X-ray. If it is normal X-ray, differential diagnosis may include contusion, sprain or strain, radial head subluxation, burners or stingers. If there is abnormal X-ray finding, maybe fracture or dislocation. Is there systemic symptom present, fever, irritability, fatigue, headache, sleep disturbance with or without swelling? Consider CBC with differential, blood culture, ESR or C-reactive protein, urine analysis, muscle enzyme, ultrasound, X-ray, MRI, bone scan. If there is a normal finding, differential diagnosis may include myalgia, myositis, fibromyalgia. If there is abnormal result, differential diagnosis also may include myositis, rhabdomyolysis, sickle cell crisis, osteomyelitis, bone tumor, leukemia, and neuroblastoma. If the history is suggestive of growing pain, differential diagnosis, of course, of growing pain. If there is erythema or swelling present with or without fever, central papule or punctum visible. If it is yes, this is insect bite, puncture wound, or superinfected foreign body with or without cellulitis. If it is there is no central papule or punctum, differential diagnosis also may include cellulitis, contact dermatitis, complex regional pain syndrome, or insect bite. If there is numbness or tingling present, consider X-ray, specialty consultation, neurology, orthopedics, for EMG with or without MRI, differential diagnosis, nerve compression, which may include carpal tunnel syndrome, ulnar nerve entrapment, cervical disc herniation, and thoracic outlet syndrome. If there is history of swelling or pain persistent for more than 5 to 7 days in the absence of obvious systemic symptoms, obtain X-ray of the affected area. If it is abnormal, differential diagnosis, fracture, intentional versus unintentional, dislocation, osteomyelitis, bone tumor, myositis ossificans, leukemia, and neuroblastoma. If the X-ray are normal, obtain CBC with differential, ESR, or C-reactive protein. If it is abnormal, consider MRI versus bone scan. If it is abnormal, differential diagnosis, as we mentioned, osteomyelitis, bone tumor, fracture, intentional versus unintentional fracture, shin splints, stress fracture, and leukemia. If it is normal, this is contusion. If it is normal CBC and ESR or differential, observe for 1 week. If the system resolved after 1 week, this is contusion. If the symptom does not resolve, a patient need MRI and bone scan, as we mentioned. If their history of overuse or pain well localized on arm, hand or wrist, leg or foot, consider X-ray. If it is in the hand and wrist, differential diagnosis, paronychia, carpal tunnel syndrome, tenosynovitis, ulnar neuritis, ganglional cyst, Kienbock disease, osteonecrosis of the carpal lunate, congenital trigger thumb or finger, rhinoid phenomena, radial head subluxation, and erythromyalgia. If it is in the leg, Differential diagnosis: shin splints, growing pain, stress fracture, tibia vara, Blonnet disease. If it is in the shoulder, this is overuse injury, maybe instability, tendinitis, subluxation, rotator cuff injury. If it is in the foot, differential diagnosis: a plantar wart, ingrowing toenail, bunion, tarsal collision, plantar fasciitis, severe disease, calcaneal apophysitis, Achilles tendinitis, accessory navicular bone, puncture wound with or without foreign body, poor fitting shoes, osteonecrosis, finger infraction, cochlear disease, and erythromyalgia. If it is in the elbow, this may include overuse syndrome, apophysitis of the medial epicondyle, little Lego elbow, Panner disease, osteochondritis dissecant capitellum, lateral epicondylitis, tennis elbow, medial epicondylitis, golfer elbow, radial head subluxation. If it is in the hip, slipped capital femoral epiphysis, avascular necrosis of the femoral head, leg calf Perthes disease, iliac crest, and apophysitis. Radial head subluxation, Nersemide elbow, is most commonly the result of the preschool age child being lifted upward by an extended arm. This upward traction caused the annular ligament to partially slip off the radial head. The history is generally the key to diagnosis. X-ray findings are non-specific, but films should be considered to rule out other injuries when the history is unclear. Burners or stingers are transient neurological injury of the brachial plexus due to compression or traction. Transient severe unilateral pain extends from the shoulder to the fingertips. A combined weakness and numbness may occur if bilateral or affecting the lower extremity. Spinal cord injury must be considered. Mild to moderate muscle aching, myalgia, are common with the many viral infections. Lab value, if obtained, are generally normal or consistent with the viral illness. A more severe viral-related myositis present typically with the severe calf pain and difficulty or refusal to walk 5 to 7 days after an acute onset of viral, most commonly influenza B symptoms. Adolescents with juvenile fibromyalgia often experience headache, fatigue, sleep problems, anxiety, and subjective sensation of joint swelling, pain at several sites, at least 4, with the typical tenderness at several points. Most experts consider a 3-month duration necessary for the diagnosis. Shin splints, medial tibial stress syndrome, are the most common overuse injury of the lower leg. They present with the diffuse tenderness along the lower third or half of the medial tibia. The pain onset is initially toward the end of the period of the exercise, but with the progression will be present throughout activity. Imaging is not necessary for diagnosis. A contusion of the quadriceps muscle may be complicated by ossification of the hematoma, myositis ossificans, causing pain and stiffness for several months after the injury. Growing pain, benign nocturnal pain of the childhood, are common. Children complain of bilateral diffuse extremity pain, usually in the legs, thighs, or calf. It typically occurs late in the day or at night and does not affect daytime activity. Massaging characteristically produces relief in these children. In contrast, massage would aggravate pain in most serious conditions. The physical examination is normal. Pain that is unilateral, localized to joint, or persists during the day should never be assumed to be growing pain. Nerve compression manifests with the tingling, numbness, and paresthesia, pins and needles, in addition to pain. Carpal tunnel syndrome classically present with the numbness on the radial thumb side of the hand, and ulnar nerve entrapment present with the numbness on the ulnar side of the hand, fourth and fifth finger. When arms or shoulder pain combines numbness and tingling, MRI or EMG should be considered to rule out cervical nerve compression. Carpal tunnel syndrome is caused by compression of the medial nerve at the wrist and present with the vague pain and numbness in the thinner region and proximal forearm. Tenosynovitis of the wrist present with the pain and swelling of the lateral aspect of the wrist. Crepitation or locking or stinging sensation may occur with the movement of the thumb. Ulnar nerve irritation or entrapment causes tingling, numbness, and weakness of the fourth and fifth finger. Tarsal collision may develop in late childhood or adolescent, causing stiffness and painful flat feet. Plantar fasciitis is heel pain that may radiate over the entire plantar fascial surface. The pain is typically worse in the morning and improves over the course of the day. Severe disease is an apophysitis at the site of the heel cord, Achilles tendon, insertion into the calcaneus. It is an overuse syndrome seen in children 6 to 10 years of age. Children complain of posterior heel pain with the activity. A limb is often present. Accessory navicular bones may become symptomatic in late childhood or early adolescence, with pain and tenderness along the medial aspects of the navicular bone. Freiberg disease, avascular necrosis of the head of the second or third metatarsal, causes pain in a forefoot that worsens with the activity. It occurs most commonly in 8 to 17 years old females. Cochlear disease, avascular necrosis of the tarsal navicular, affects boys more often than girls. It most commonly presents with pain in the midfoot around 5 or 6 years. The term little Lego elbow encompasses a variety of disorders in and around the elbow, the most common of which is traction apophysitis, inflammation at the site of the tendon insertion in the bone of the medial epicondyle. Penner disease and osteochondrosis of the capitellum distal humerus present acutely with the lateral elbow pain in the young, 5 to 13-year-old athlete. In older athlete, the condition is called osteochondritis dissecans capitellum. Its onset is more insidious and is more likely to be associated with a loose body. Localized tenderness over the anterior iliac crest characterized by iliac apophysitis is seen most commonly in adolescent runners, especially during growth spurt and when they are increasing their mileage. Thank you for your listening.